everyone. Welcome to our third seminar in this Bloomberg American Health Initiative Evidence Workgroup series on data resources relevant to the initiative. Really happy to have Amanda Latimore here for this third session. I'll come back to that in a second. Just want to give a quick advertisement for the final one we're going to have, which is November 15th, also at 12:15. Nilanjan Chatterjee from the Department of Biostatistics is going to talk about large-scale cohorts and how they can be used for studying topics related to the initiative. So save the date for the 15th. I don't have the room handy right now, but we'll send out announcements later. So today we're really, again, happy to have Amanda Latimore here to talk about opportunities for using data to address the opioid epidemic. Dr. Latimore is currently the Bloomberg American Health Initiative Public Sector Initiatives Lead, and in that role she supports and facilitates the bridge between academia and public service agencies and providing technical assistance for local and state agency-led health initiatives. So really at the heart of a lot of what the initiative is really trying to do in terms of bridging academic research and practice. And her background is incredibly, the reason she's in that role, she has sort of perfect background for that role. She got her PhD in epidemiology from our school and has also served in roles at the Baltimore City Health Department and the Behavioral Health System Baltimore, working on a variety of topics. So I won't take out more time talking about her background, but she's really the perfect person to serve in this role and to tell us about resources around data for the opioid epidemic. So thank you, Amanda.
Great. Thank you so much, Liz. All right. So just to give you a couple of seconds on what I've been up to as Public Sector Initiatives Lead. We've been working across the U.S. In a lot of local and state governmental agencies, typically health departments, really digging into strategies to address the opioid epidemic. So we've been in Louisiana and Staten Island. There have been a lot of really great conversations that we've had with police and public agencies alike. And so a lot of what I'm talking about here is some of the lessons learned from those experiences, but also some of the experiences I've had right here in Baltimore around data and how to really use it for the biggest impact. So I think most of us who are here and listening online are probably fully aware that we are in an opioid epidemic, and regardless of our focal areas, we understand the magnitude of the problem. So I'm not going to spend too much time talking about it, but this is just to put it in perspective that what we are seeing now is greater than the number of deaths that occurred at the peak of the HIV epidemic, greater than the number of deaths that have occurred when we started implementing seatbelt laws, and greater than all of the individuals who died in the Vietnam War, 58,000. And so last year in 2016, we were at 65,000 people. In 2017, you're looking at 72,000. And it's not looking like it's trending down. So that said, we're at the point where we need all hands on deck. And unfortunately, in academia, we're in the business of providing evidence and efficacy and effectiveness of certain programs and interventions. And the public sector, governmental agencies, they're in the business of implementing those programs. And instead of all hands on deck, we're more like ships passing in the night. And so, in my experience, most of us academics are, once we identify the evidence-based practice, we publish it in a paper, and we sort of send it off into the universe like, a Chinese sky lantern, and go forth, and someone will read this paper and implement it somehow. And the chances of that actually happening in the public sector are pretty slim. And so what I'd like to say first is I totally get it. As a faculty member, you've got a lot of strains on your time. You're teaching and you're writing grants and once you finally get funded, you're like, oh no, I have to actually do all these things. And then you write a paper and you submit, then you rewrite and you submit. And so there are a lot of demands on your time. As a student, all I'll say is 8-week terms. I get it. And so, what I hope to share with you today are some thoughts on some first comprehensive approaches to addressing the opioid epidemic, and then dig into what some of the gaps in the evidence and the research are. And then I'd like to also plant the seed that we really do, to do some of this work, we really do need to partner with the public sector, and that it can be a mutually beneficial experience where you can really have a deep understanding of the issues and have research that can be easily implemented and disseminated, and that you're meeting the needs of the public sector as well. And yes, there are challenges, and I hope to go into some of that and how to deal with those challenges. But when we work together, we all win. So the opioid epidemic has emerged in a lot of different ways across the US. And here in Maryland, it's really been this parallel process between the prescription opioid availability and the changes in the drug market for heroin. And so there's a lot of question about whether constraints on prescribing has really pushed people out into the streets and now they're using heroin. And the evidence suggests that the timing is really off for that to be the case. And yes, a lot of individuals who use heroin previously misused prescription opioids, but a lot of people who are misusing prescription opioids, it's rare for them to actually transition to heroin use. And so when the timing's off, also the implementation of certain practices restricting the prescribing usually precedes or is not aligned with the causal relationship between the restrictions and increases in heroin use. So, given that information, what does a comprehensive response look like? So we've got there are actually a couple of really great documents, and I've two of these are shown here. One of them was developed, the Opioid Epidemic, funded by the Clinton Foundation. That was developed by Caleb Alexander and Shannon Frateroli, Andrea Geelan. It's a really comprehensive look at how to respond. And the CDC report just came out about a month ago. It's actually very readable, provides evidence, and it can be used in a lot of different settings. And so I'm not, the point of the talk today is not really to go through all of the evidence behind each of these strategies. That's already very well described in these documents. I'm really just trying to give you an overview of what the responses are and how we can use data to further those the evidence base of those responses. And so you've got 3 big buckets: prevention, treatment and recovery, and harm reduction. And so in the prevention bucket, you really need to focus on preventing the initiation of opioid misuse, and then promote safer prescribing, as well as the alternatives, because you can't restrict prescribing and not offer alternatives. And you've got treatment and recovery, so you really want to increase access to life-saving drugs, medication-assisted treatment, and have quality care and linkages to that care. And then harm reduction, you've got the naloxone overdose education, and supporting innovative initiatives. You're looking at safe consumption spaces and really advanced surveillance. So in prevention, promoting safe prescribing can really reflect the CDC guidelines. So they just released guidelines in 2016. And so opioids should not, if any of you don't know this, opioids should not be the first line of defense for pain management. And when opioids are used, the CDC says that they should be given at a low dose for short durations, and if longer durations are needed, you really need to follow up every 90 days to make sure it's still the right course of action. And so state adoption of these standards can really promote the change of culture that's needed among providers, many of whom are still in the previous normative approaches to prescribing opioids. So education of providers are needed. Patients also need to have different expectations on what their providers should be doing to manage their pain. And the use of academic institutions is really important to help train up students who are coming through, who will be prescribers in the future, and also provide CEUs to current prescribers. The use of prescription drug monitoring programs is really important as well, because you really, it's a great tool to understand not only what's happening in your offices, but elsewhere. And so doctors need to be trained on how to use this and mandates to use them. And there should also be someone overseeing the extent to which providers are using the PDMP. It's important to have flags in there, so not just relying on providers to look into the database, but identifying, having unsolicited data come to the provider saying, hey, watch out, this might be a dangerous situation for the patient. And also interoperability with health information exchange systems, as well as having interstate access, because an individual who's doctor shopping can easily just go to another state where they have a clean slate. So you really want to have those systems communicate. Another prong in the prevention area is increasing access to alternatives. So as I said before, for those who are not yet misusing opioids, they need to have other ways to manage their pain that are accessible. And for those who are currently misusing, they need to have connections to treatment that are quality services. And so you want to increase the coverage and incentives for the non-opioid pharmacologic as well as the non-pharmacologic. So yoga and physical therapy are really important approaches. And so insurance companies need to start covering those effectively. You want to remove barriers for prior authorizations and improve reimbursement limits. And then the safe disposal component is something that hasn't been very well studied, but safe disposal options like take-back programs, drop boxes, and mail-in programs have shown to actually increase safe disposal. But the purpose is, one, to have misuse, have decreased misuse of opioids, and also to improve the water quality. And neither one of those things have really been studied very well. And then there are a couple of universal prevention programs. This is ESPERT, not well studied in terms of the opioid epidemic and impact on it. And then there are a couple of youth-focused programs. So there's one in Iowa that did an intervention, family-based intervention, at the age of 12 to 14, and then looked at 25 to see if there were impacts on opioid misuse, and the answer was yes. So what are the research gaps in prevention? You've got the issues with PDMP expansion, and there are a lot of promising aspects to the use of PDMP. It can actually increase provider confidence in prescribing opioids, but at the same time, there can be a lot of hesitance. Providers can be concerned about their, about legal ramifications if they make the wrong decision. Patients might be really nervous about asking for opioids. They don't want to be labeled as someone who's misusing, and so they may not be asking for the care that they need or reporting that their pain actually isn't being managed well. And there is also some evidence that when PDMPs are used, they're mandated, regulated, and monitored, that providers are able to successfully decrease risky prescribing and also provide referrals and connections to care. And so expanding on that is an important focus for research. And basically all of the prevention activities that I mentioned in the previous slide need more research to understand its connection to mortality and other health outcomes. So there's also a question of whether or not there's sufficient pain management capacity. Unfortunately, it's really difficult to track where all the services are, and so that's one thing that we can do is provide ways to capture this data. So we can say, you know, a jurisdiction can say, we just don't have enough capacity for pain management. Well, is that because capacity is actually lacking, or because there's not enough communication about where services are? Or there's some, stopgap or a problem where pain management physicians aren't having enough referrals or able to serve to their full capacity. And then is Medicaid reimbursing? That's an important aspect. And in some jurisdictions we've worked in, capacity exists, but not for those with Medicaid. So providers actually aren't accepting Medicaid, even though it is reimbursed. The role of trauma as a precursor is also a very important aspect that needs to be studied, and addressing the needs of individuals who have comorbid mental health and substance use disorder is really an untapped area for research. So what are the data that can really speak to each of those areas, and some of those areas that I just mentioned? So when you're trying to look at the impact of some of the prevention strategies and the impact on mortality, overdose, fatal and non-fatal overdose. So you've got your county and metro data, and a lot of that's publicly available. So NASDA provides substance use, prescription drug misuse, drug initiation, and perceived risk from use, and substance use disorder data. And CDC Wonder is a really good resource for publicly available data on overdose, different substances as well. And if you're looking for something a little more specific, because as you know, within the city of Baltimore, there are a lot of communities, and those communities vary very much in the context in which people make their health-related choices and actual outcomes. And so taking a deeper dive from this publicly available data into, data that has a lot of potential for good collaborations with the public sector is important. So, potential data sources is the prescription drug monitoring data. You can connect some of the overdoses with, what prescribers. I think a lot of prescribers actually don't end up knowing that their patients have overdosed, and so giving that information back to prescribers and identifying how that changes behavior with prescribers is an interesting question. You can look at the context in which doctor shoppers exist. So patients who go from doctor to doctor may do so in communities that have certain kinds of risks. And I'm certainly not advocating flagging individuals and doing some sort of promoting penalties. I think promoting treatment connections is really the way to go if you're looking at individual identification of doctor shoppers. So your death record data is really a complicated topic, and in a lot of areas, death record data is months and months behind, if not years. And so, and that's really a reflection of the system. There are chief medical examiners. Here in Maryland, we've got a gold standard OCME. So we're very lucky here. But in other states, in other communities, they don't have that luxury. They may have coroner systems, and coroners can actually, they're elected officials, and this is not their full-time job, and so they could have really wide ranges in terms of their skill in documenting deaths. And so that's part of the reason why there's so much variability in the quality of the data and the timeliness of the data. And so really the data are generally confirmed when they've reached vital statistics and come back to the jurisdiction. And so using some of that data to identify outcomes, connecting it because those are individual level data. If you've got a good partnership with the public sector, you'll be able to, and they can overcome data sharing challenges, you can connect that data to a lot of interesting sources in terms of risk. Non-fatal overdoses is one way. It's a proxy for fatal overdoses, but it's also an outcome in and of itself, because there are far more non-fatal overdoses than there are fatal overdoses. And so some of the ways that you can get at more timely data is to partner with first responders, police, EMS, because they actually have access. They're the first ones on the scene. And there are some challenges often with identifying, because they can't actually do toxicology right then and there. So some of the ways to overcome that is to say, okay, an EMS arrives at the scene, they administer naloxone, and the person revives from naloxone. And so generally, naloxone is used as a diagnostic tool. And so individuals who aren't overdosing from opioid use aren't going to revive. Individuals who have taken too much and aren't going to be revived aren't part of this non-fatal data anyway. So Essence is also, this is hospital-based data. The Department of Defense developed this originally as a bioterrorist biosurveillance tool, and it's been taken up by the CDC and jurisdictions, including Maryland, across the US, providing hospital data, more timely information on non-fatal overdoses. And then, of course, you've got your Medicaid claims data. So that could really give you an understanding of your pain management capacity, because you can look at the claims and see what providers are where and what services, on what date, to whom they're providing those services. And so that's a really good opportunity to understand this issue of capacity for alternatives to opioids. All right, so you've got treatment as another bucket, the second bucket. And medication-assisted treatment is one of the most important tools for addressing the opioid epidemic. It's associated with declines in risk of overdose, fewer arrests, greater employment, more connections to services and engagement in services. But the level of coverage really varies by state. So you've got this really good, this great map by the Pew Charitable Trust, which has a strong focus on expanding medication-assisted treatment. And it shows you just the variation across the US, at least, I think 29 states provide all three, reimbursement for all three medications. And so improving the reimbursement rate is an important approach, all three, because every person needs something different, or not everyone needs the same thing in terms of medications. You want to remove insurance obstacles to medications. Prior authorizations are a huge barrier, because that means that if you show up, you're ready for treatment. The time is now, actually, to get the treatment, not later after you've got the authorization and the doctor, you come back for an appointment, because between that time that the prior authorization or the authorization was requested and the time the person comes back, an overdose could have happened. And so we really want people to get the medications at the time that they request them. And then there are a lot of different ways you can approach expansion of medication-assisted treatment. Ken Stoller, who's here at Hopkins, has the co-op model. There's a hub and spokes model that comes out of Vermont, where you've got the hubs, which are opioid treatment programs, providing kind of the intensive services, and then you expand. Once those services, the patient is stabilized, they go out to primary care, doctors, and office-based services. And when there's decomposition or increased services are needed that the primary care physician can't meet, then they go back to the opioid treatment program. And that's been taken up by a lot of states across the US. Other treatment and recovery approaches is to really ensure this linkage to care happens, particularly in non-traditional settings. So you've got your hospital-based and criminal justice settings that really we should be targeting for linkages to care. And so we want to train our physicians to identify individuals who are at risk and know how to appropriately respond by connecting them to services. So the proper protocols, procedures need to be in place and the right kind of training. Physicians need access to addiction specialists. So we're not asking physicians to know and do all things. They need to have a resource to go back to when they have questions. It's important also, so this idea of linkages to care in the criminal justice setting is probably one of the highest impact things that we can do, because individuals who are released from prison or jail are at a much higher risk of overdose, 56 times the risk of overdose compared to the general population. And so that's low-hanging fruit for how we can address the opioid epidemic. And in some areas like Rhode Island, where they implemented medication-assisted treatment in prisons, they found a 60% reduction in overdoses among that population. And overall in the state, a 12% reduction, which can be attributed back to implementation of MAT in the jails. And so another important point is, yes, we should increase capacity, but do people know that the treatments exist, where they are, and do they have good access points? And so this is where things like information lines and treatment locators are really important, and having public information, public campaigns on treatment, connections to treatment. So once people access the treatments, they need to have quality care. And so improving quality is another important component to the treatment bucket. Promoting this chronic illness model is probably one of the first steps, and not using abstinence as the only positive outcome is important. Recognizing that individuals go in and out of misuse, treatment, recovery, incarceration, going back and forth is important. We don't expect people who've got diabetes or cardiovascular disease to always, stay directly on what they're prescribed and what they're recommended to do. And this is, substance use disorder is a brain illness, and so we need to recognize that. Excuse me. And so in doing so, we would recognize that supportive housing is important and more long-term supports. Because traditionally, we basically say, okay, here you go, here's your detox and your inpatient, and after a couple of weeks, you should be good to go with the skills you need to be in recovery long-term. And that's just not, that's not where the evidence is now. There are great standards that we can use to reflect on whether or not our services are up to the quality that they need to be, and reimbursement really does need to be aligned with those standards. And finally, addressing the needs of women and families is important. Women may need particularly different resources like childcare. They also really respond well to group-based services, has shown to increase engagement. So using those approaches are important. So what are the gaps in knowledge? You really, in terms of new research, we should think more carefully about how information lines to connect people to services are used, the impact of those information lines, the quality of those information lines, because if the information line is just someone calling up and someone on the other end reading off a list of treatment facilities, not engaging in warm handoffs, not knowing whether or not that facility has capacity, is probably not going to be that impactful. Or do people even know about what the access points are for treatment? We need to look more carefully at individual treatment trajectories. So how people engage in services, what works for who, and what works for whom, and how people are transitioning from acute services to lower levels of care, and engagement long-term and retention in services is an important outcome to study. And reflecting back on what I previously said about redefining abstinence as, the gold standard for outcome is really, redefining that is really important. We also don't know what the impact of treatment expansion is. So if we expand on medication-assisted treatment, what does that actually do in terms of overdose outcomes and other health-related outcomes? Do we have the capacity? Do providers have the capacity? There was some research that was done in Baltimore City that I worked on to look at how many how many buprenorphine doctors were waivered in Baltimore City, what their capacity was, how many individuals, if they reached their max for what they were waivered for, how many individuals they actually provided services for. First of all, not all of the providers were on the SAMHSA locator. About 70% of them did not consent, so we don't actually know where all the providers are. And so we use proprietary data to fill the gap there. But providers who we were able to capture, of those providers, the average treatment capacity was about 50 individuals, and they were only treating or prescribing for about 17 of them. So we probably need more providers, but more importantly, we need to support the providers that we do have, and that's where the hub and spokes model comes into play, because you can have the opioid treatment programs that have this specialized care provide that support for the office-based prescribers of buprenorphine and other medication-assisted treatments. And in doing so, expand the capacity of the city. We also need to have a better grasp on what a functional behavioral health system looks like and what the performance metrics are for that. And looking more carefully at population-level outcomes. Longitudinal studies of medication-assisted treatment are really needed. I mentioned the Rhode Island study before, but that was sort of a point-in-time estimate, and what would be really impactful, I think, for evidence is to be able to follow people, know what they did before they came into jail in terms of treatment, what they received in the prison system. And so going from pre-arrest to jail, to transitions to prison, to post-release, getting the connections to care that they need, and what that does for overdose and other health outcomes would be really useful. And then peer-based services are an important component. Involvement in peer-based services is shown to improve treatment experience, so people are more satisfied. But there are a lot of other outcomes I think we could capture, and it's been difficult to do that. So having academics like you really focus on that would be helpful for the field. So what data are available? Well, I mentioned before, using the treatment locator. SAMHSA also has the data on waivered physicians. That is useful, but recognize its limitations. So you've got providers who don't consent. SAMHSA will actually send you a data file if you request it on the non-consenting prescribers, but there isn't information on the prescriber. It's sort of cleaned of the identifying information. But you can still use it to look at different jurisdictions, because it's got kind of broad zip codes, I think is what they'll be able to send you. So the PDMP is a great important source for understanding capacity and prescribing practices and the impacts of expansion, because you can look at changes in time before and after treatment is expanded on prescribing, and look at requirements for reporting and changes in treatment. So opioid treatment programs are actually prohibited from reporting to protect individuals who are engaged in substance use disorder treatment. And so that's one limitation of the PDMP data, but office-based buprenorphine providers are required to report in the PDMP, so understanding the limitations is important. You can supplement some of the limitations of that for buprenorphine prescribers by getting your hands on some proprietary data from private insurers and pharmacies and pharmaceutical companies. And there are a couple of faculty here that actually use some of these data sets, and so collaborating with them could be useful. Treatment capacity and treatment trajectories I've already mentioned, and you can use Medicaid claims data to do some of those analyses because it's basically panel data. So you have an individual claim for each service, the provider they used, the date of service, and you can connect all of those rows of data over time to do these kinds of analyses. SAMHSA has a CAS tool. So let's say you actually can't capture the treatment capacity using any available data. You can actually bring in some of the social determinants. It's an algorithm that they use. So you provide demographics of the community and a couple of other key inputs, and then it will tell you what the predicted capacity of that community is. And so capturing all of that the treatment data and connecting it to population outcomes like fatal and non-fatal overdoses, visits to the hospital related to opioid use disorder and patient stays is something that you could focus on. So some of the research that I've done here in Baltimore related to treatment came from individuals who refused transport after overdose, and EMS arrived at the scene. They revived the individual, and the individual refused to be transported to the hospital. And so they sort of represent a high-risk population that's difficult to link to care. So we asked them, a subset, to talk about what happened, why they refused care, and what we could do to better connect them to treatment. And pervasive in all of the answers, it was, it's not the right time. They're suffering from severe withdrawal symptoms after being pumped with naloxone. And it's sort of like asking someone, imagine that you've got the flu and someone comes to you and says, hey, I've got this really good workout program. It's time for you to get healthy. It's not a good time to ask that question. And so individuals who responded about why they didn't want to be transported or get connected to services, that it's just not the right time. Give me some relief for this feeling of the willies. And for those that would be willing to go to the hospital, said that once they got there, they actually weren't given any sort of resources. There's one person who said that their discharge papers in bold underline said stop using heroin. Those are the discharge instructions. And so if you suffer through your withdrawal symptoms, you make it to the ER, you're sitting in the ER waiting room, still experiencing these withdrawal symptoms, and what you waited for was for a nurse to say stop using heroin, the calculation of how important it is to actually get into the EMS vehicle is a little different. So understanding the importance of what connections, linkages to care actually occur in the ED, and taking that into consideration is really important. Ramping up our response in the emergency departments is something that we ought to really focus on based on this research. And then some of the other factors were, fear of disclosure or arrest. People were worried that once they got to the hospital, that their other providers, that were treating them might cut off their medications because they overdosed. And there were other, interpersonal issues like family finding out. And some of the factors related to EMS were that, they didn't want to engage with EMS at all because nobody wants to be Narcan is a common response. People have suggested, the naysayers have suggested that, we shouldn't expand naloxone because people would just use more. They'll engage in higher risk drug use. And the reality is nobody wants to be Narcan. So they're not trying, the expansion of naloxone isn't, a compelling reason for individuals to engage in riskier drug use. This is interesting. Individuals who refused transport said that they were tired of being treated like animals, and they just wanted to be treated like a normal person. And guess what EMS said? I just want to be treated like a normal person. So they're overextended. They end up coming back multiple times to the same community, sometimes to the same person. There's a huge increase in what they're being asked to do. They drop somebody off at the hospital and the nurses treat them poorly. The individuals who they revive are not very happy with them. And so there's this, kind of confluence of issues, exacerbates individuals who are revived not feeling like they're treated like a normal person, and then EMS feeling the same. So some of the implications I've already mentioned are changes in hospital-based responses, finding a way to ease withdrawal symptoms, which could be induction in the ED. And then recognizing that right after an overdose might not be the critical moment to have people introduced to the idea of care, or connected to care. And so peers being involved in this process and maybe coming back later, coming back to connect with individuals who have been revived at a later moment might be an important response. And alternative destinations like sobering centers could also be promising. So we've got the third bucket, which is harm reduction. This really, some of the key strategies are around changing norms, changing perceptions, changing hearts and minds, and recognizing that addiction is a chronic illness, and so that's among prescribers and also patients, family members, public at large, first responders. Expanding overdose education and naloxone distribution, making sure pharmacies are stocking naloxone, having standing orders, and insurance coverage for naloxone. Rapid response teams are being used where you hotspot where overdoses are occurring and sending out rapid response teams. Often those response teams have peers and individuals with lived experience as part of the group. We really should be discharging individuals from treatment with naloxone, particularly those who have been released from prison, but also individuals who've been recently released from treatment, and as well as those who've been prescribed benzodiazepines, because all of those things are risks for overdose. Peers, focusing on peers at multiple touch points, having safe places like sobering centers, safe consumption, syringe exchange. And then Susan Sherman's done some really great work here at this school on fentanyl testing and drug checking. And so those are promising areas for continued research. And then Good Samaritan laws are standard approaches to harm reduction. Individuals who come to the rescue or come to the scene of an overdose are often fearful that helping someone could lead to arrest, particularly if they're engaged in drug use. And so Good Samaritan laws are meant to protect individuals who help at the scene of an overdose. But the problem is that often what they actually experience at the scene of an overdose is not in line with the spirit of the law. So did some research here and captured the experiences of individuals who were being served at the needle syringe exchange program here in Baltimore, and asked them what actually happened when they experienced an overdose themselves or revived someone. And what we found is that often, more often than not, individuals, some knew about the Good Samaritan law, but more often than not, individuals who knew about it did not have a lot of confidence that police were going to respond in kind, that it would make any difference whatsoever in how police responded. So confidence in the law is important. Knowing about the law is the first step. Second of all, do they have confidence? There were lots of stories of individuals who, were frisked and threatened to be taken in for manslaughter if they didn't provide information on the drug supplier, or it could have been related, something completely unrelated, maybe a crime that happened the day before, and using that overdose situation as a means to extract information. People's phones were taken away. And so what's really important that came out of this research is that police practices need to be, policies and procedures need to be in line with the spirit of the law in order for these Good Samaritan laws to really work. So implementation, following through with public information campaigns, as well as making sure that all of the players are responding with practices that are aligned. So this is one example of harm reduction strategy. This particular project called Bad Batch, which is a collaboration with the Baltimore City Health Department and the Fire Department, was an attempt to get more timely data on overdoses. So we used EMS data to automate hotspotting. So bringing in that information, processing it, and sending out notifications. And the third goal was to disseminate this information to the community with the hopes that if you were alerted, you're an individual who uses, or you're a family member of or friend of someone who uses, that information can be powerful. And there were a lot of issues when we tried to roll this out. People were concerned of the unintended consequences of sharing this information because individuals who use would just rush to the area that the hotspot occurred in. And so we built in, after having some really informative and important conversations with individuals who use and individuals who are in recovery, we made some adjustments to the tool. And so, the key point here is that you can't just roll out these technologies who are intended for individuals who use and the community without asking the community and individuals who use what the implications of your work is. And so some of the things that we identified is having larger geographies. So individuals wouldn't really know exactly where to go, which dealer to go to if they wanted to use this information in the wrong way, quote. But the broader strategy of harm reduction means that it's not really for us to decide what information we should give someone or not give them because they might use it the wrong way. It's really to say, hey, here's some information you could use to manage your risk. And later, if you're ready, since we're developing this trusting relationship where I'm giving you information that's useful, I'm here if you want to engage in other services. And so that's really a pillar of harm reduction. And so this text-based service, which notified the community when overdoses hotspots were identified, also had a built-in suite of commands for identifying where you could get treatment, naloxone training, and a couple of other things. So 5 minutes? Oh, geez, okay. Some of the gaps in harm reduction is understanding the supply and demand, individuals who seek fentanyl versus don't, evaluating the impacts of peers and OE&D rapid responses, individuals who have polydrug use, impacts of standing orders, role of the private sector is important. Individuals who use need jobs, and how do we engage employers in this? And then predictive modeling. Some of this is actually already happening using shared data across many sectors to identify individuals who are at risk for overdosing is something that's happening at the state level, but more can be done there. There's available data, much of which I've already talked about, but you could also partner with the city or the state to look at where naloxone is distributed. Reversal data could be used. Again, OCME. Forensic toxicologists at the police department have information on, they have drug sample data, so you can identify not just as after at autopsy, but before, when drugs are seized, what they contain. And so a big part of the presentation, which I will not really be able to dig too much into, is some of the lessons learned from public sector engagement. So it's supported by the Bloomberg American Health Initiative. The importance of what we're doing being applied cannot be emphasized enough. It's at the core of what we're doing. We weren't meant to, this is John Snow, he sort of the father of epidemiology, and he didn't identify the source of the outbreak and say, hey, I'm just going to write this down. He actually demanded a meeting and implemented a change based on what he found. There are lots of trends affecting why we should move towards practice-based work. There is a lot of discourse, at least in the world of epidemiology, about moving towards consequentialist epidemiology, looking at the usefulness of our research, not just looking at sort of the gold standard RCT and having, very little bias. So getting the data really has to do with being better at public sector partnerships, understanding that they're too busy putting out fires to engage in the work in the way that you're used to. We're trained to talk to other academic folks, and so we really have got to do better at distilling down the most important pieces, knowing what you know, communicating enough that you're credible, but then throwing the rest away when you're translating. And so these are just some of my experiences on the differences between what I was trained to do and what you actually face in the public sector. The good news is that you don't have to reinvent the wheel when you're involved with public sector. DASH, data across sectors for health, is an important resource. You can see here that some of the priorities are looking at mapping resources, needs, health risks. Academics are really good at doing that. Also sharing data for specific purposes and visualizing the data is something that we could support the public sector in. This is a resource that my good friends at this Baltimore City Health Department, Jonathan Gross, he created this infograph for me that shows some of the availability of data and how we can use GIS tools to provide different useful infographics for the public sector. And some of the do's and don'ts quickly is that you really need your partners to generate your research ideas, your research agenda, because when it comes from them, not only do you benefit from really understanding what's needed out of research, but they get their needs met. And once you build that trusting relationship over time, where it's obvious that you really care about their needs, then they're more likely to help facilitate the research on your end. Don't ask for everything in the kitchen sink. Know exactly what your use case is, what data you really need, balancing the burden and benefit. And don't conduct analyses for the sake of analyses, which goes back to making sure that you're research agenda is generated by the partners, having this more reverse research approach. And always, always triangulating the data, asking your partners, does this really reflect experience that you have out in the field? Knowing how to translate that in a way that's meaningful, visually compelling, and then making sure you always disseminate the information back. Here's some of the benefits of public sector partnerships. Here's some ideas on how you can make the case, because there may be some public sector partners that say, I don't have time for data and evidence, I just need to do something now. And the reality is, if you don't use evidence and data, you actually are at higher risk. You don't have the luxury of not using evidence and data because you have to respond so quickly. People's lives are at stake, so you have to use, with your limited resources, things that are known to be effective. There are opportunities for faculty and students. One very important one is the public sector consultation funds that we have here at the university for faculty who want to get involved with public sector work. And you can do some of the things like identifying measures to track the opioid crisis and response, implementing dashboards, bringing evidence to practice and strategic plans. You can convene partners. For students, there are service learning courses where you can really get involved in addressing the needs of the public sector. And for both students and faculty, you can translate and disseminate to traditional audiences. And so I'll just run, these are some examples of translation. And in conclusion, we really have a vital need to incorporate evidence-based strategies into our responses to the opioid epidemic. And these partnerships with the public sector are hugely important in making that research happen, making sure that it's useful, that it has a big impact. And it's not in these small incremental ways that we're used to engaging in research, where we kind of inch along and we equivocate and we say more research is needed. How many of you have written at the end of your papers many times, more research is needed? Right. We all have, and so having more impactful research is what we need right now. And to do that, we need public sector partnerships. And so the academic institutions, Hopkins included, should really work together. It'll be mutually beneficial, and we'll have the greatest impact on policy and practice by doing so. There's my contact information in case you're interested in the slides I skipped. Actually, I think they're going to be available.
Good. Hopefully. Yeah, we'll work on that. Let's thank Amanda first. So that was a great overview. I feel like I learned a huge amount, both about the epidemic, what we can do about it, and how we might study it. So thank you. And motivating for better partnerships with public sector. We have a couple minutes. So if people have a question, we'll ask you to speak into the mic so that the people watching online can hear us.
Hi, thank you. My name is Alona. I'm a PhD student in health behavior and society. So my question is, what is your recommendation of strategies to decide between whether we need more research or better implementation of what we already know? Because some of the research gaps you identified in other settings, for example, with the criminal longitudinal studies of MIT, in other settings have been investigated and they've shown incredible results. So that's my question.
Yeah, I don't think we have to do just one. I think that we can implement useful strategies based on the evidence that we have, and then also, while we're doing that, further research agenda by digging deeper into what works, what the levers are, why it works, what we need to focus on in terms of that particular strategy. So having a research perspective as well as implementing what we already know, I think can go hand in hand.
All right, we'll let Paul have the last. People are anxious.
Thanks, Amanda. That was great. I was wondering about, Something you mentioned, the worry of accidentally causing harm with the alerts for overdoses, and
Right.
people know that's where the more potent stuff is. I think that comes up a lot with some projects that we pursue wholeheartedly. And I've worried, as a psychiatrist who treats people with addiction on the inpatient unit, I've worried about things like test strips, for instance, because I know that a lot of the patients I treat want to find the neighborhoods. How much do you think we should worry, and how much do you think we should just be open to experimenting and as you said, leave the choice up to the potentially vulnerable person?
Yeah. Well, we don't want to shy away from innovation, right? But when we do pursue some of the strategies where we're not really sure where it's going to land, what the consequences, the unintended consequences are, I think it's really important to engage in conversation with the folks that we're hoping to serve, as well as local experts who can really weigh in on the context of decision making of the system. And I think using that approach, you're likely to lift up some of the unintended consequences if they do exist. So being mindful of it is the first step, and not just going home without thinking about. So you're already there, but then bringing in individuals with lived experience, maybe folks that that are in your setting that you can bring back to talk to about their experiences. And first of all, what can be done better, but some negative experiences. So reaching out to folks who fell off and it didn't come back is really important, just as important as those who stayed.
All right, I think we need to wrap up so the class that's anxious to come in can come into the classroom. Thanks again, and again, here's all of Amanda's contact information for more